not sitting setting currently, but we'll try to cover every aspect which is possibly related to what you would want to see in the labor room. Learn about how to use those instruments. Today we'll be discussing primarily about vacuum assisted vaginal birth. The next Friday is about forceps and subsequently cord prolapse and other things. So basically we wanted to have a drill kind of a session for you all where you can actually see, get your hands on clear about how to use these operative vaginal delivery instruments. So subsequently, we'll be uploading videos on our app, which will be directly recorded in the labor room. So currently, it is not possible in a live lecture because of the logistics that at this hour you cannot get the labor room access everywhere. Since I'm working in a government setup, it's not possible. Sometimes the instruments are not available. There is only one backup, and sterilization and other things become an issue at night hour. So I hope you all understand with that. More importantly, vacuum ventouse assisted vaginal birth is a very, very important topic from Viva point of view on your table rounds when you'll have. So ventouse will be kept, forceps will be kept. So you'll be asked to pick up any instrument of your choice and demonstrate how to apply that instrument, right? And you'll be asked every possible question from head to toe about that instrument. So you should be really, really thorough about any kind of operative vaginal delivery. We all know that operative vaginal births are becoming an obsolete art given the rise in cesarean sections. Okay, but as an obstetrician, see, a cesarean section can be done by a general surgeon also. In my city where I am currently, more than half of the cesarean sections are done by general surgeons. But normal vaginal birth is conducted by DIs, by staff nurses, by other people. What both of them can't do is operative vaginal birth. That is completely and entirely in the hands of obstetrician. So as residents, try and learn as many as you can. So, actually there's a guideline which says who are well trained to apply forceps or vacuum. It was designed for interns. So first you have to observe at least 20 to 25 operative vaginal births. You should have assisted at least 10 operative vaginal births, like some SR is applying and you're assisting them. Then you should apply at least 5 under supervision. Okay, 1 second, I have a message. Your screen is not visible. Is my video visible, Krishna?
Yes, ma'am.
I have not started my screen yet. I will start writing. I'm just talking to the residents.
Okay.
And so this is about this is how you'll be actually going and applying your instrument. So without wasting much time, let us start and begin. I was talking about who are well trained. So only after so many observing, assisting and applying under supervision, you'll be confident enough to apply instruments. Luckily, when I was a resident, we had a couple of SRs coming from J&K and Himachal, like Shimla trained people. So these being hilly places, whatever cases were referred to their hospital during training, our SRs were so confident because they knew that from here we cannot refer a patient outside or anywhere else, and their OTs for cesarean would be heavily busy, as our SRs told us. So they were so apt and accurate in applying forceps that by repeatedly assisting them when I was a first time JR, I developed a really good confidence. I was a person who had not conducted a single vaginal delivery during my internship. I had not assisted also, but everything I learned in my first semester. So, being residents, if you give maximum time in your labor room during your residency, even if you hate obstetrics, dedicate these 3 years sincerely in the labor room and you learn a lot. You learn everything which you can't learn for the rest of your life. So remember that. Okay, without wasting much of your time, precious times, let us begin with today's topic. Let me start. So today we'll be talking about ventouse, which was previously called as ventouse. Now we call it vacuum assisted vaginal birth. Let us see what all we'll be talking about. We'll be talking about the instrument, indications, contraindications, prerequisites, about the procedure in detail, and what are the possible complications that we can anticipate. So first, let us study about the equipment. So there is a cup, there is a tube. I deliberately am drawing these. I'm not using I have images from internet, but you already see all of that. Okay, so this is the cup which goes on the fetal head. There is a corrugated tube which transmits the suction pressure. This goes and attaches to a suction machine. Which has pressure gauge, and you can monitor the pressure or control the pressure accordingly. So first, starting about this cup. So there are three types of cups which are available. First is a soft bell, and then there is a metal cup. So these are the three types of cups which are available. I'm not writing down the individual names. I have a slide where I have given different companies and different names of the cups, because this is a important Viva question. What are the different types of cups available and which are the ones that you use? They ask you this during your Vivas. Let us go back to a little bit of the history. It could be one of your OSCE question about the history, or it can be asked in Viva as well. So first was Kobayashi Celastic cup. This was a bell-shaped cup with a diameter of 65 mm. You don't need to know anything more than that, but just because it's a Viva question, you should be aware about the name, what kind of a cup was used. Let us understand what are the prerequisites for any operative vaginal delivery. I will be writing as OVD, operative vaginal delivery. What do you think can be? So there are characteristics which are relating to the pelvis of the mother. There are characteristics related to the cervix, that is a Bishop score. Then there are characteristics related to the fetus per se, and obviously the person who's applying. Person, passage, and the passer. Right? This is how we read about pelvis assessment and all these things. How? So first, most important requisite for this, any kind of operative. This includes both ventouse and forceps both. Cervix is fully dilated and retracted. Why I have mentioned dilated word separately and retracted separately? Because possibility is there, when there is labor dystocia, that is prolonged labor, when things are not progressing, cervix might be fully dilated, that is 10 centimeter, but there is a thick rim. Anterior lip of cervix has a thick rim which is overhanging the fetal head. You might have observed obstructed labors, malposition, that is occipito-posterior positions. Whenever you have the thick rim of anterior lip and it is not going for like 1 hour, 2 hours, edematous thick anterior lip, think that it could be an occipito-posterior position of the head. So that is called as retracted. Like cervix is not completely retracted on the fetal head. That is why dilation is separate and retraction is separate. Second important prerequisite is that membranes should be ruptured. Third is fetal head should be completely engaged, engagement of fetal head. Fourth is position of fetal head has been determined. Like you are sure of position of the fetal head with respect to the ischial spines. Ki kahan pe, what is the station of the fetus there? Fetal weight has been estimated appropriately. ऐसा नहीं होना चाहिए that to a macrosomic baby which is like more than 4 kg or more than 4.5 kg, you're thinking कि भाई ये तो labor में जा रहा है, fully dilated आया, membranes ruptured and I'm applying a forceps.